Great pleasure to be here, and since we have so little time, I'm just going to get right to it. So the topic of my talk today is opting for twins in IVF, and the paper came out of a working group at the Hastings Center, which was about single embryo transfer, and whether that is something that should be encouraged or even possibly mandated. And the talk today is derived from a paper that I wrote on this, I found, extremely interesting topic, which is coming out in the Oxford Handbook of Reproductive Ethics. So multiple births are generally recognized as an unfortunate outcome of infertility treatment, especially what's called high-order multiple births, triplets and more, triplets and quadruplets and quintuplets. And these rose more than 400% in the 1980s and 90s. Twin births didn't increase quite that much, but they increased 76%. Now, in recent years, the rate of high-order multiple births has gone way down, and partly this is due to improvements in fertility treatment. They don't have to put in as many embryos as they used to, and the fertility drugs are getting better as well. There's a widespread consensus among practitioners in fertility medicine that high-order multiple births are a bad outcome and something that needs to be addressed, and they've already started to address it. But there's a lot less agreement among practitioners about twins. Should twins be regarded, like triplets and more, as a bad outcome? Should the desirable thing be one healthy baby and one healthy mother, as some say? Or is it an acceptable outcome and something that's really left to the discretion of the prospective parents? Or is it even a desirable outcome, as one infertility expert from Israel who has said, you know, the more the merrier, and they contribute a lot, and why not? It's a good thing to have twins. Economic use of resources. So most professional organizations have come out with statements saying that the aim of IVF is the birth of a single healthy child. But despite this, the rate of twin births has continued to rise. So clearly, practitioners are not following the advice of statements from the American Society of Reproductive Medicine and the Society of Assisted Reproductive Technology. In 2010, which is the last year for which there is data, the rate of twin births in assisted reproduction was slightly over 33 per 1,000 births. That may be a misprint. I think it's 133 over, well, I'm going to have to check that. But anyway, it's much higher than the natural rate of conception of twins. Twins occur one in about 250 pregnancies. Now, why are there so many twins? Well, some of it has to do with the fact that women who are older are having more babies, and twins are more common among older women. But the primary reason is infertility treatment. And there are two kinds of infertility treatment that can lead to multiple births. One of them is in vitro fertilization, IVF, and embryo transfer, where the eggs are taken out of the woman's body artificially and inseminated in a petri dish, and then the resulting embryos, 1, 2, 3, whatever, would be implanted back into the woman's uterus. It has been common in past years to put lots of embryos back into the woman. And some of you may have heard about the case of Octomom, where a woman gave birth to octuplets, and actually the doctor had put 14 embryos back in her uterus. Why? He was a terrible doctor. He had never had any success. He was astonished when all 8 implanted. But in any event, it's not really the famous cases like Octomom that are really of concern for public policy because they're rare. But twins are not rare. It's a very common outcome, so it's much more serious. The other kind of infertility treatment is called controlled ovarian stimulation, or COS, and there the woman is given superovulatory drugs to make her ovulate and ovulate more. And that also obviously can result in twins, because if more eggs come out, then there's more eggs available to be fertilized. And it's much harder to control, obviously, than IVF, because in IVF you have the decision. Am I going to reimplant 1 embryo, 2 embryos, 3 embryos? But with COS, all you can do is see how many eggs are there and see how many have been fertilized, and then call off the cycle if there's too many eggs. Some people think that it's really COS that is primarily responsible for the increase in twins, and that if that's the case, single embryo transfer is not really going to address the problem. And that may be true, but it does occur for about 16% of the twin births in the US, and it is also true that if single embryo transfer became the norm for good prognosis patients, that is, patients who are under a certain age and haven't had problems with IVF cycles before, the rate of twins would be significantly reduced. So this is something we could do, even if it would not address the whole problem of twins. Sweden adopted a single embryo transfer, and unlike the United States, where there is no federal legislation or even state legislation governing the practice of fertility medicine, in places like the UK, where you have the HFEA, in cases like Sweden, they can say what fertility doctors can or cannot do. So what they said was that for the most part, except in very exceptional situations, the plan was going to be single embryo transfer, and they reduced the rate of twins from 35% to only 5% without reducing the birth rate. So some people have said we should follow Sweden's model, and we should strongly encourage or even mandate single embryo transfer. And so even if controlled ovarian stimulation would also reduce the twin birth rate, and even if it might be more important than single embryo transfer, IVF offers us a way to virtually eliminate twin pregnancy for IVF patients. I say virtually because there's always the chance that a single embryo could split after it had been transplanted, but that's fairly rare. So now comes the question, is opting for twins justifiable? Is this a choice that prospective parents should be able to make? And those who are in favor of it, those who think that twins are either an acceptable outcome or even a desirable outcome, make a couple of claims. The first thing that they point out is that the research shows that many IVF patients, indeed perhaps most IVF patients, want twins, right? And so they say we have to respect patient autonomy. As long as they are informed, they get to choose what we do. It's not our place as fertility doctors to tell them how many children to have. So it's not only patient autonomy for medical decision-making, but it is also procreative autonomy, that people have a right to decide how many children they want to have. In response, it should be said that if you're going to respect patient autonomy, you do have to make sure that choices are informed. And in fact, a lot of people have no idea of the additional risks that are imposed both on mother and babies by twin pregnancies. Some say that this is because media glorification of famous twins, or twins are so cute and you can dress them alike. But it turns out that it's been found that if you do educate patients about the increased risk, they are more likely to say, okay, I think single embryo transfer is a good idea, and to give up their initial preference for twins. But even if patients have the right ultimately to make their own decisions, that doesn't mean that these choices are immune from moral evaluation. And that's really what I'm talking about now in this paper today. How should we regard morally opting for twins in IVF? Now, I'm going to say two things which are relevant to policy, but I don't think are relevant to the question of moral evaluation. One of them is the risk to the woman herself. Carrying a twin pregnancy does increase the risk to the woman. There are additional medical risks. But while that's certainly something a woman should consider, I think that comes under the heading of prudence, not moral obligation. You can take risks with your own health if you want to, and that doesn't seem to be immoral, although it might be stupid. I also am not going to consider the additional economic costs of twins. These are considerable because most often twins, certainly higher order multiples, but even twins are often premature. They have to then go into the NICU. It's very expensive. I mean, the NICU can be, $1,000 a day. Again, definitely relevant to social policy, but I don't think it's directly relevant to patient choice, because I don't think that patients have a moral obligation to choose the cheapest medical intervention for themselves. They should choose what's in their own best interest, although they may, if they're very public-spirited, also want to consider cost as well. So I'm not going to consider either of those two things. For me, the central moral issue to be considered is between the interests of the patients or the couple, their desire to have twins, and the increased risks that are imposed on offspring. Do their interest in having twins outweigh the risks that are imposed on offspring? And the reason I found this topic so interesting is because it raises a number of fascinating, both empirical and conceptual issues, and even the empirical issues are not that easy to resolve or think about. So why is it that patients often say they want two embryos transferred, double embryo transfer, or DET? Well, first of all, patients say that it will increase their chances of achieving a pregnancy, kind of intuitively. Well, if one will get me pregnant, don't I double my chances if I have two in there? And the surveys of patients have found that even if they understand that this increases the chance of serious disability in one or both of the twins, that's a better outcome from their perspective than having no child at all. So even some educated patients still want double embryo transfer. Secondly, most people who undergo infertility treatment, at least in the United States, don't just want one child, they want two children. And if they do want two children, this is called two for the price of one, right? One round of infertility treatment and you get your family all at once. And infertility treatment, in the United States anyway, is an expensive proposition. So people might be able to pay for one round of infertility treatment, but not two. Also, the process itself is burdensome physically. It's not a walk in the park, so some would rather do it once and get two children out of it. And then finally, older patients especially, women who are in their late 30s or early 40s may say, I may not get pregnant again, and I don't want to risk not being able to have the second child by having two rounds of single embryo transfer. Now, let me go back a second. These, I think, are serious reasons. They are not frivolous reasons. They're not about twins will be cute and I want to be like some movie star that just had twins. These are serious considerations and deserve to be taken seriously. But now let's talk about health risk to offspring, which is the most pressing moral issue, I think, here. About half of IVF twins are born prematurely at an average of 35 weeks. And more than half of them are going to be low birth weight, which today is considered to be under 5.5 pounds. And this increases morbidity and mortality. They're more likely to die, although that is a little controversial. Preterm birth increases the risks of respiratory disorders, cerebral palsy, sight and hearing impairments, and long-term learning disabilities. So one of the kind of interesting philosophy of science sort of questions that comes up now is, how should we evaluate the risk in order to see whether we can balance it against the interests of the parents? The first thing that Norbert Gleicher, the one who thinks twins are actually desirable, points out, and I think he's absolutely right about this, is some of the literature compares an IVF double embryo transfer and a twin pregnancy with an IVF single embryo, a single pregnancy. Well, if you think about it for about 2 minutes, you realize that's not the right comparison, because whatever the risks are for, and there's always risks in every pregnancy, even in a non-IVF pregnancy, the risk of serious disability is about 2 or 3%. IVF tends to have lower birth weight, and so in general, and so there are perhaps more risks, but 2 pregnancies are going to be, what? Double the risk. So it really isn't fair to just compare a twin pregnancy and a singleton pregnancy. You have to compare a twin pregnancy and 2 singleton pregnancies. If you look at the literature about how risky twin pregnancies are, even if you make the right comparison, what you find is that the experts do not agree. Some studies show an increase in mortality, some show no increase in mortality. Some show a significant increase in disability, some show less increase in disability. So what is a poor philosopher to do? Well, what I say in my paper is I think looking at all of the literature, it is reasonable to conclude that twin pregnancies impose additional risks on offspring, even though the experts do not agree on just how risky. At the same time, it is also true that most twin pregnancies result ultimately in the birth of 2 healthy children. That is, even children who spend some time in the NICU ultimately end up healthy. Not always, and obviously. And the disabilities may be fairly mild, like learning disabilities that could perhaps be addressed with appropriate educational techniques, but as sometimes they are very grave indeed. But there are plenty of twins walking around, and they seem fine. Now, the fact that most twin pregnancies result in the birth of 2 healthy children, however, isn't the only thing we need to consider, because riskiness itself shouldn't be evaluated just by how things turn out. If I leave my toddler in the bathtub while I go to answer the phone and she doesn't drown, you're not going to say, well, you didn't do anything risky. She didn't drown. No, it was risky, right? So you have to look at riskiness, not just, well, most of the time it works out okay. One really important issue, I think, is whether it is true that double embryo transfer improves the chance of pregnancy and single embryo transfer decreases the chance of pregnancy. Because if someone is not going to get pregnant at all, that is a very serious reason. People who undergo infertility treatment really want to have children. This is very, very important to them. And again, looking at the literature is very, very interesting and trying to understand it, because most randomized clinical trials that compare single embryo transfer and double embryo transfer do demonstrate that the pregnancy rates are higher with double embryo transfer. However, before you say, well, that answers the question, now we know double embryo transfer is better, randomized clinical trials, by definition, do not distinguish between favorable and unfavorable prognosis patients, right? That's what we mean by randomized. You take all of the patients. And so what physicians who support single embryo transfer say is, we're not talking about all infertility patients. We're not talking about a woman who's 43 years old and has already had 2 failed trials. We're talking about women who are, in one case it was defined as under 38 and has not had any failures, a good prognosis patient. And when you make that qualification, then there doesn't seem to be much difference between single and double embryo transfer. Another thing that's very important is the ability to identify good quality embryos. And here's a kind of an irony. In the United States, because of the abortion debate and because of the many conservatives who want to preserve the lives of embryos, it became impossible for fertility doctors to do the kind of research on embryos that would enable them to identify good quality embryos, which would increase the birth rate. So here's one of these maybe unforeseen kind of an unwanted consequence of something that was supposed to be morally right. So that's all very important. The other thing that's very important for improving the birth rate, improving the pregnancy and birth rate, is improving cryopreservation techniques. And all of this has been done and is being done, but this is a little plea for more research money too, and fewer legal restrictions. Okay, so conclusion is that single embryo transfer need not reduce the chances of getting pregnant in good prognosis patients, but I do qualify that by saying it depends on the skill of the practitioner. Clinics differ widely, and some are very good at getting women pregnant, and some are not. As I said, the doctor who took care of Octomon was a terrible doctor, and he is fortunately no longer a doctor at all. So, okay, now we get into the theoretical or philosophical issues. The argument that people ought to opt for single embryo transfer is that there will be less of a risk of disability in offspring, a considerable reduction in risk of disability. But how bad is disability? So there is something called the disability critique, which says that a lot of our attitudes towards disability and people with disability is based on ignorance about what the lives with people with disabilities are like and prejudice against people who have disabilities. So scholars like Adrian Ash, for example, have pointed out that when they actually talk to people with disabilities, it turns out that their lives are about as happy or unhappy as the lives with people without disabilities, and that most people living with disability find their lives well worth living. So what they also say, the disability critique criticizes the so-called medical model, which says that the problem with disability is that it's a medical condition that's bad, and they offer a social model that says it's not really the medical condition, it's how society adapts to that condition. If you provide ramps for people with wheelchairs, if you provide methods for people who have disabilities to be incorporated into society and to participate fully, then that's the way to try to address disability, not by preventing the existence of people with disabilities. And Ash and her colleague David Wasserman have written about specifically prenatal testing for disability and selective abortion. And they have argued that this expresses a bad attitude, a bad parental attitude, that people shouldn't want to terminate a wanted pregnancy because they find out that the child has some disabling congenital, genetic, or chromosomal condition. They think that if you do that, it shows that you're either ignorant about disability or prejudiced against people with disabilities, or you have a bad attitude about what it is to be a parent. You should be willing to welcome into your life a child with even a serious disability. And they also think that by choosing prenatal testing and selective abortion, they harm existing disabled people by contributing to stigmatization and stereotyping of people with disabilities, that their lives are just not worth living. Now, Ash and Wasserman never wrote about twins. They wrote about, but in an article that I wrote in which I criticized Adrienne Ash's view, I said, if we take the disability critique, parts of which I think are very, very important. I mean, I stand here against prejudice and discrimination. But I think that her view about being against prenatal testing and subsequent abortion is inconsistent if she's in favor of abortion generally, right? And also, if you say that there's nothing wrong with being disabled, what about preventing disability? For example, women are encouraged to take folic acid during their pregnancy to avoid spina bifida and other neural tube defects. So they did consider that, and what they said was that the morality of the choice for prenatal testing and selective abortion depends on what you're expressing with this choice. If what you're saying is, I wouldn't want any child with a disability, they think that that expresses a problematic parental attitude. But if what you're saying is, well, I could have one child that would not have a severe disability versus two who would, that isn't so problematic. They're not against taking folic acid during pregnancy to prevent spina bifida. So I think that they're wrong about the disability critique, partly because I think that they underestimate the difficulties in raising a child. But I also think that they are wrong to think that even taking folic acid during pregnancy might express a bad view. And it seems to me that if a woman, because they think it could be permissible not to take folic acid during pregnancy, right? I'm willing to accept a child with spina bifida. And that just seems wrong to me. I think that a woman who refused to take folic acid during her pregnancy for no good reason would harm and wrong the child who came into the world with spina bifida. So I think what we should say is preventing avoidable harm is not merely permissible, as they think, but morally obligatory, absent pressing countervailing reasons, which I can't think of any, but perhaps there could be. Now, the non-identity problem. This is another very difficult one. I'll be talking more about this when I give my departmental lecture, but I'm just going to do it very quickly here. There's an argument that goes like this. It says, even if the worst comes to the worst and both twins have severe disabilities, they cannot claim that they were harmed by mom's choice to have two embryos implanted. Why not? Well, first of all, we have to accept the premise that their lives are going to be worth living, right? Accept that premise, despite the disability. Secondly, what if mom had only chose single embryo transfer? Only one gets born, right? Now, admittedly, the one who gets born is more likely to be healthy and whole, but neither twin knows if is it me? I'd like to be the one who gets born, right? And what this argument says is, isn't it better to be born with a disability than never to be born at all? And therefore, the mother can say to the two twins with disabilities, aren't you glad to be here? Had I chosen single embryo transfer, one of you wouldn't be here, and while I'm sure you're both glad that the other one wouldn't be here, You don't know, but it might be you. Therefore, neither of you have a legitimate complaint against me. And then the mother can say to society, if they have no right to complain, why don't the rest of you butt out? Because what is your right to complain now against me? I think the non-identity problem can be handled. I do think we need to distinguish between two kinds of harms. One kind of harming is straightforward harming of a specific individual. A woman who binge drinks during her pregnancy and has a child with fetal alcohol syndrome, which was caused by the binge drinking. Might be difficult to show that, but we'll skip that over. We can say she has harmed her child because had she abstained from excessive use of alcohol, this child would have been born without fetal alcohol syndrome. This child would have been born mentally normal, healthy, and whole. There's another kind of case, however, which are called the non-identity cases, where the only way to prevent the harm is by preventing the birth of the child, right? So, for example, and they pop up all over the place, but for example, we might say to a very young teenager who wants to have a baby, you shouldn't have a baby now. You'll give your child a much better start in life if you wait till you're older and more mature and physically more capable of carrying a healthy pregnancy. But if you think about it for a minute, she can't make this child, the one she would have if she got pregnant at age 14, she can't give that child a better start in life. She can only give a better start in life to a different child, the one she would have if she became pregnant at 18 or 21 or whatever, right? There's no way for her to improve the chances for this child. And that's what makes it a non-identity problem. You have to change the identity of the child to prevent the harmful condition. Now, some people say, well, if it's a non-identity problem, then you have no moral obligation to act differently because you haven't harmed this child. If you do what everybody's urging you to do, this child will never get born. And while most children born to 14-year-olds might wish that mom had been older, that ain't possible, right? If mom had been responsible, this child never would have been born. I think that we can get around the non-identity problem by saying that where you have a choice between bringing into the world a child who will be healthy and whole and a child who will be disadvantaged, and there's no other countervailing moral considerations, you do have a moral obligation to substitute. It's a contentious claim, but I'm going to make it. But in any event, I don't really think that SET poses a non-identity problem after all, after suggesting that it might. And here's why not. Because in assisted reproduction, what would be most likely to happen is you would freeze all of the embryos and only implant one at a time. And so if you don't implant both at the same time, you can still implant the second embryo later, so the twin can say, yes, I would have been born, right, but healthy and whole if you had done it in two subsequent pregnancies. Therefore, it's not a choice between life with disability and no life at all. And that, I think, makes SET more like a standard case of harming and less like a non-identity problem, and I think it strengthens the moral obligation of good prognosis patients to accept single embryo transfer. I think it's morally right for them to do so. But I just want to conclude by pointing out that individual moral choices are not made in a vacuum. Practitioners also have responsibilities. I think they ought to start following the recommendations of their own professional societies, and to be sure that they're really educating their patients about the increased risks from multiple pregnancies. There are economic reasons that lead patients to prefer double embryo transfer, and these also should be addressed, such as insurance coverage of IVF. If a woman knows that her rounds are going to be covered, she's much more likely to accept single embryo transfer. So that's something that we need to work on. And we need to improve fertility treatment so that we can be more likely to enable people to have a healthy singleton. All of these need to be addressed in order to enable and help patients to make morally responsible procreative choices. Thank you.
Thanks, Professor Steinbock. Now let's welcome our discussant, Professor Ho-Mun from Department of Public Policy at the City University of Hong Kong. Thanks.
Yeah, the title of my commentary is "Should the Disability Critique be Taken More Seriously?" And I think it has been taken seriously. But I think Professor Steinbock could make a bolder critique, bolder attack of the disability critique. When I got the draft of her paper, and I just know, oh God, I am reading a paper with arguments and conclusions that I agree. What can I say? Should I say yeah, and then just go away? No, and so maybe put it negatively. Oh, I'm now playing the role of a devil's advocate, but I'm not. I'm a real devil because she's on the side of the truth. But to put it positively, maybe I just try to make some suggestions to make her argument stronger. And Professor Steinbock has raised some important point about the scientific background for the moral discussion, and here is a very crude summary. The first point is multiple embryo transfer is no longer needed for maintaining a better successful rate of IVF for favorable prognosis patients. But some patients would still prefer double embryo transfer to single embryo transfer because of their wish to offer twins in IVF. But there there are evidence that the risk of disability for IVF twin pregnancy is higher than that of two IVF singleton pregnancy for favorable prognosis patient. And I find her point very convincing. But I'm a philosopher and not a medical scientist, and maybe our colleagues in the field of medical science may have a different view. And many people's after reading my last point, many people's gut feeling is that it's wrong to give birth to IVF twins, given the assumptions that the risk of disability is higher. But the advocates of disability critique would think otherwise, and they think that the disabled and the non-disabled should be treated as equals. They are of equal moral status. So according to them, prenatal testing and selective abortion could be regarded as discriminatory, right? But it seems to me that in her paper, Professor Steinbock hasn't made a direct attack at this position. And at some point she said, even if the advocates of disability, the word even if, I just highlight here, even if the advocates of the disability critique are right in arguing against prenatal testing and selective abortion because they imply a discrimination of the disabled, their critique is wrong about IVF twin pregnancy despite the increased at risk of disability. And I think she may have make a concession that's too much. And I think she may need to strengthen her arguments by attacking the disability critique about prenatal testing and selective abortion, because her critics may argue that her arguments also presuppose a discrimination against the disabled, and they believe that it is morally wrong, and that's why they think that it's wrong to have prenatal testing and selective abortion of a fetus that is likely to have disability. Let's take a look at some of Professor Steinbock's argument. And she argues that refusing to take measures to prevent harms, but she used the word harms, but not disabilities. And some people would say that, oh, she had, I mean, her view has already been biased and questions backing. So refusing to take measures to prevent harms in the case of IVF is wrong, as much as a woman who binge drinks and has a child with fetal alcohol syndrome. Doesn't this imply the life of a disabled is less worthy? And there are some blind couples have argued that they should be allowed to give birth to a blind child on the ground that blind and non-blind people are of equal moral status. So some would still say that, oh, there is a discrimination here in this argument. And then Steinbock's argument may well be challenged by the non-identity problem. According to, the problem, I mean, it's a very brief summary of the problem. So no harm is created by giving birth to IVF twins with disabilities, since the one who is supposed to be harmed would not have existed if single embryo transfer had been chosen. So no one is harmed. Again, Professor Steinbock used the word that we can handle the problem. It looks as though the problem is there. But I think we may make a bolder attempt to say that, well, the non-existence is something, is better, maybe better. So have we lived in a world without Hitler, or have we lived in a world without me? The world may well be better, right? So maybe the problem is not there. And then but she handled the problem, non-identity problem, in this way. She should make an analogy. Delayed pregnancy enables the teenage to have a different child who will enjoy a better life. So two single IVF pregnancy can give birth to the substitutes of IVF twins with high risk of disability. But doesn't the balance of desire to have children against the increased risk of disability to offspring presuppose the life of a disabled is less worthy? So if the disability critique is right about prenatal testing and selective abortion, based on the ground that regarding being disabled is bad or is a harmful condition, it may also be right about Professor Steinbock's argument, because her arguments also sometimes presuppose that being disabled is something bad or being harmful. And so the couples that I talked about earlier in my example would say that, no, we prefer offsprings that is blind. What's wrong with it? Okay, thank you.
The reason I didn't attack the disability critique more directly is because I did that in an earlier paper, and I do reject, I mentioned it, but I didn't go into it in perhaps as much detail as I might. It seems to me that if I take the disability critique seriously to this extent, I do think that many of us, all of us, have incorrect ideas about the lives of people with disabilities, and we should be better educated and better informed. And that many people have, not to put too fine a point on it, ugly attitudes towards people with disabilities. And that's a bad thing. We should try to get over those attitudes. And we should try to make our society as inclusive and welcoming as they can, so that everybody can participate to the best of their ability. Having said that, I don't think having a disability is neutral, and I think that responsible parents will, of course, wish to prevent disability in their children, and that the failure to prevent it, for example, by taking folic acid in pregnancy, is exactly like binge drinking in pregnancy. But that's a straightforward kind of harming. That's a specific fetus who could have been born healthy and whole. Now, the people like Adrian Ash and David Wasserman think that there's a difference between prevention of a disability in an individual and preventing the individual from coming into existence. Part of the debate has to do with, then, really the moral status of the fetus and abortion. Because if you think, as I do, and as Adrienne Ash always did, that abortion is a permissible choice, then what the woman is saying is, I am not yet a mother. If I were a mother, I would take care of this child, but I still have a choice. It seems to me that if you can make that choice of abortion because of other burdens, financial, or it would interrupt your education, or the relationship has gone sour, or whatever reason, or I'm not ready to be a mother, I don't see why you couldn't legitimately make that choice because of the additional burdens that are imposed by having a child with a serious disability. So I don't think you can both be pro-choice and say that prenatal testing and selective abortion is specifically wrong. And that's why I reject the disability critique. I don't think it necessarily sends a message. I don't think it's necessarily discriminatory. I don't think it conveys the message that their lives are worth living. I think it's more like prevention. And just as someone would, if you wouldn't say to the woman, you're taking folic acid, what, do you don't like people with spina bifida? No, that doesn't follow. So if you look at abortion, as a pro-choice person I do, as a form of prevention, then it would seem to me that it would be more like taking folic acid. But as I say, in this paper, I don't think I really have to convince anybody about that because I don't think it really raises a non-identity problem anyway, and if it doesn't, then it really is much more like straightforward cases of harming. One other thing I want to say, though, is when you talk about non-existence being better, I think the question raises better for whom? In the cases I'm considering people who will have lives that are well worth living. Most people with Down syndrome will have lives that are well worth living. We shouldn't pretend that the choice of abortion is to benefit them. It's to benefit the couple, the family, who do not want to take on the additional burdens of having a child with a serious disability.
Thank you for this really excellent and interesting talk. I think I agree that disability is a bad thing, so that like causing a risk of disability to another person is something that we have prima facie reason against doing so. I also agree both with your treatment of non-identity problem and your points that this case does not necessarily raise the non-identity problem that's standard in the philosophical literature. But I'm just wondering whether all this lead to your conclusion that it is not permissible to opt for a twin in IVF, okay? I think we have to draw a distinction between like what is nice to do and what is like more obligatory, okay? So I think we all impose risk on others all the time. Let's just take a stock example, we drive, okay? And as long as we drive, okay, we cause some risk of causing serious disability to other pedestrians or other road users, etc. But we think that's okay because, like, well, we give some important interest to autonomy, and we think that in many cases, as long as the risk is not too great, we allow the interest of autonomy to trump other people's interests of not being risk of not subjecting to a risk of getting disabled. So I'm thinking like what distinguishes that kind of case from IVF. Okay, if the risk is not too great, okay, as you have mentioned, okay, most twin babies, okay, are born healthy, even in IVF cases. So if the risk is small, then why can't we say that, well, the autonomy of the parents from the risk of the potential babies in this case, such that while it's morally nice for them to go for the single baby, it's not more obligatory for them to do so.
Thanks. Yeah, I think I agree with you in most places of your argument, but I'm not sure about the final policy implication. I guess this is very much following Peter's comments. Given that different parents, different couples may live in a different, environment, and they suppose a very high age couple, and their clinic available is not very good quality. They desperately like to have a child. So in that kind of situation, maybe they will balance risks, relevant risks, different from other couples, and so on and so forth. So is that eventually, even if given all your argument and reasons, a lot of them I very much like, and still at public policy level, we leave it to parents and physicians to make decisions about their particular cases. Would you agree with that, or you would like to think about we should ban the twin IVF technique or applications?
Thank you for your interesting talk. I just want to raise a question about the non-identity problem. I just want to suggest and see whether you agree or not. I mean, it seems to me that I already thought that that's not a real problem for the following reason.
What?
Okay, let me explain. Let me explain. Okay.
I've spent 20 years on it.
Okay. Okay. Let me explain why I think. Let me explain why I think that. Okay. Suppose someone is born with a defect because of a drug negligence of a drug company. Okay, and so this person has been born, whose life is worth living, right? And so this person cannot sue the drug company, right? So I mean, because in order to sue the drug company in tort law, damages must be proved. But since there's no damages, right? Because otherwise this person would not have.
Otherwise he wouldn't have been.
He wouldn't have been born. Yeah, exactly.
Not
so,
a normal negligence.
Right, right. I mean, so he cannot sue. But what I want to say is it unethical for a drug company to have done or failed to do what it's supposed to do? I think the answer is of course. Now the problem, the reason why I think it's not a real problem is because it's a conflict of two different perspectives: the ethical and the legal, right? So I think the legal perspective of being able to prove damages in the law of tort is one thing. It does not imply that there's no ethical problem in it. I mean, that's how other ways I look at it. So I think unless we accept the assumption, which is the first one, that in order for there to be ethical wrongness, one must prove damages in the law of tort, for example. So you see, so I just want to say it's a conflict of a two perspective, and there are lots of cases in which I can make some example if you like.
Well, I'm going to start with Hans and go backwards. I don't think the fact that there are non-identity problems in the law means that there aren't non-identity problems in non-legal kinds of cases. Once you become aware of them, they pop up all over the place. I think it's a solvable problem, but I don't think it's an easy problem because people keep wanting to say, oh, but think of the poor child, and you can't answer it that way because that poor child wouldn't be here at all, and as long as the child has a life worth living, it's hard to see how that child can say, oh, you did a terrible thing to me. But I'm going to reserve that for our departmental seminar, the full question. Peter and Ruping's questions are similar but slightly different. I'm going to go to Peter first. You said you agree that disability is a bad thing. You agree that single embryo transfer isn't a non-identity case, but you don't think that I can conclude that there's a moral obligation to accept single embryo transfer. You left out in good prognosis patients, by the way. That's very important. But then you made the distinction between what it's nice to do and what it's obligatory to do. And you said if the risks are not too great, and after all, most twins are born healthy, why doesn't autonomy trump? Well, what I'm arguing for is the moral obligation of parents, and not a public policy one. I agree with you that we can't, especially in the United States, we would have no way of making this mandatory. What I think we should have is more and more clinics adopting it as their standard of practice, the way their own professional societies tell them, and more patients accepting this as the right thing to do. So I think it depends on what their reasons are. I mean, if, for example, it's not a good prognosis patient, totally different situation, and that was your situation. They're older, they may never get pregnant again. That changes it. I also think that if they say, we don't have the money for 2 rounds, I don't think that that completely alleviates their moral responsibility to think about the children, but it also means that we as a society have a moral obligation to reduce that economic motive. So that's what I would say. I would say if they have the money, or if better, society pays for it, and then they still say, but we want one and done, or worse, but twins would be so cute, then I think you can criticize them morally for their choice. So it really makes a difference what the situation is and what their reasons are. But in general, I think that good prognosis patients should at least very seriously consider single embryo transfer, and not to do so would be a failure of moral obligation, not just what it would be nice to do.
The happy conclusion, I just wonder whether we can be so happy about it. So the idea is that if we decide not to, have the twin embryo, we just, save one and have pregnancy later. My question is whether this later born person, is it the same person? Because it's a later born, and so the time of birth is different, and it's also the case that the relationship of this person with the important people around her will be very, very different. So for example, if she was born as part of a twin, being a twin, I believe, is a very, very important part of a person's identity. So if she's born later, then I think, and she's born not as part of a twin, then I think arguably she is a different person. So if that is the case, then can people still complain that somehow it's a situation of discriminating against a potential person who is disabled?
Okay, hi. Okay, so it's not a question, it's about I want to hear about your comments on the Julian Sabalesko, the procreative beneficence, because we talk about we should prevent harm from the unborn baby, but the Julian Sabalesko, he talked about the procreative beneficence, which is that we should do the best to get the best child. Well, there are other claims that it's not about the do no harm, it's about the do good, or some say to do the best for the unborn baby. What do you think about his? What's your view on his take on? And then he actually kind of developed the idea about the disability, that we're not really discriminating disability. We shouldn't discriminate a person with disability, but however, disability is bad. So we should discriminate disability, but not to discriminate a person with disability. So what's your view on that?
All right, so my question is about economic cost. You mentioned in the very beginning, economic cost should not be included in the moral consideration. But then when you answer Peter's comments or questions, you kind of slip in this economic consideration when the patient doesn't have this public funding. If the treatment is done by the government, then we have to take that into account. So I just wonder in what condition economic cost should be relevant in moral sense.
Great questions. So let me start with yours, because you're right. It seems like I said in one case, when we're evaluating the moral choice, we should not be saying, well, these ICU babies are so expensive, and that's what's wrong with the choice. And then later I said that we as a society have an obligation to enable people to make the right choices. So what I'm saying is economic factors can lead people, can put pressure on people to make bad choices, less than desirable moral choices. And where we can change that, we should try to do so. But what I'm saying is that the content of that choice is not primarily determined by the fact that it's going to cost society money. It comes in order to help people make the right choices, but the morally good choices are not, at least directly, influence. I don't mean that you should never consider them. My husband will divorce me if I say that, you know, because he thinks that we should always be thinking about how much it costs. But I'm more of a like, okay, yeah, I'll think about that later. But first, let's talk about me and what's good for me. And I think that's the most important point. I hope that answers your question. As far as Julian Salviolesco's Procreative Beneficence, what do I think about it? Sophistry. I don't see why anybody has an obligation to have the best child. I think we do have an obligation to try to mitigate harmful conditions. I think we should try to be good enough parents. But I don't, and I even think it's a little dangerous to be thinking that way. I think that is what leads to people trying to get their kid into the right preschool so they can get right into the right kindergarten. And stop, you know. So I don't believe in that stuff. And Cindy raises the question about identity. Isn't the later born person, if there's two pregnancies, a different person than if you had had the twin pregnancy? Now, there's two things I want to say to that. Suppose it is a different person, so what? I mean, the harm of not being a twin or not getting the benefits, perhaps, of being a twin would seem to me to be outweighed by the serious physical disabilities that might be imposed. So, but I also don't think it's a different person, and here's why not. I think that we should follow David DeGrazia in making a distinction between numerical identity and narrative identity. And while I think narrative identity is definitely affected by whether you're a twin or not, and some people start out as twins and then get rid of the other twin in utero, I think that might have an important effect on your narrative identity. I think you're still the same individual because you come from that particular egg and that particular sperm that created that particular embryo. So I think it is the same, but even if it isn't, I don't think it would matter.
Okay, now it's time for coffee break. Thanks.
Good.